Hello everybody and welcome to our module on urinary infections. Let's start by talking about the different categories of urinary infections. Cystitis means infection of the bladder, and this is sometimes referred to as a lower urinary tract infection because, as shown in this picture, the bladder is in the lower portion of the urinary tract. Pyelonephritis is infection of the kidneys, and for the same reason this is often called an upper urinary tract infection because the kidneys are the upper portion of the urinary tract. And one important concept to understand about urinary infections is that most infections ascend, and by this I mean that bacteria gain entry to the urethra and then they ascend into the bladder causing cystitis, and then they go up to the kidneys and cause pyelonephritis. And this is important clinically because most patients who have pyelonephritis will first have symptoms of cystitis because the bacteria have ascended through the system. The most common etiology of urinary infections is E. coli. This causes up to 95% of all urinary tract infections. Some of the other bacteria that can cause infections are listed on this slide. These include Proteus, Klebsiella, Staphylococcus. Staph aureus can cause infections, including MRSA, and then another variant of staph, Staphylococcus saprophyticus, also commonly causes urinary infections. And then finally, Enterococcus and Pseudomonas can also cause urinary infections. Let's talk about the clinical features of cystitis. The three classic symptoms of cystitis are dysuria, frequency, and urgency. Dysuria means pain with urination. Frequency, as the name implies, means going to the bathroom a lot. And urgency means always feeling like you have to urinate. In addition, many patients have suprapubic pain. Importantly, however, patients with isolated cystitis, meaning isolated infections of the bladder that do not involve the kidneys, usually have no systemic symptoms and usually have a normal white blood cell count. If systemic symptoms are present or if the white blood cell count is elevated, this suggests that the diagnosis is pyelonephritis. Now let's talk about the clinical features of pyelonephritis. First of all, as I said before, most bacteria ascend through the urinary system, so patients with pyelonephritis often also have symptoms of cystitis. First they develop the cystitis, then the bacteria climb into the kidneys and they develop pyelonephritis. But beyond the clinical features of cystitis, patients with pyelonephritis also have systemic symptoms like fever and chills. They can have flank pain, which means pain on the sides of the abdomen. The costovertebral angle, or the CVA, is where the ribs insert into the spine. Basically, it's the back of the abdomen. And if you tap this area in a patient with pyelonephritis and elicit tenderness, that's evidence of CVA tenderness. Because there's inflammation in the kidneys in pyelonephritis, some red cells will often leak into the urine, and you can see hematuria. And then finally, the classic finding on urine microscopy in a patient with pyelonephritis is the presence of white blood cell casts. This is a picture of a white blood cell cast on the screen here. These are formed as white blood cells move through the lumen of the nephrons. The diagnosis of urinary infections is usually based on clinical findings plus a urinalysis. Importantly, a urine culture is not routinely done. This is reserved for complicated cases, and this often comes up on your board exams. You don't need to send the urine for culture. If you have clinical evidence of an infection plus a urinalysis that's abnormal, that's enough evidence to begin treatment. So let's talk about what the findings are on urinalysis in patients who have urinary infections. First of all, the urine is often cloudy in patients who have urinary infections, and so sometimes before you even analyze the urine, you can surmise that there is an infection present just by looking at the urine. If you do a urine dipstick test like shown on the screen here, you can identify the presence of leukocyte esterase. This is an enzyme produced by white blood cells in the urine. The urine dipstick can also identify nitrites. Nitrites are produced by nitrates, which get converted to nitrites by bacteria, and 90% of UTI bugs can make nitrites. Importantly, most gram-negative rods like E. coli can make nitrites, so therefore the urine dipstick is going to show nitrites in the majority of cases. There are a couple of exceptions. Enterococcus and Staph saprophyticus do not make nitrates, so you can sometimes have a negative nitrate test, but most of the time the nitrates will be present in a patient who has a urinary infection. Let's talk about some of the risk factors for urinary infection. First of all, women are 10 times more likely than men to get UTIs. There are a couple of reasons for this. First of all, they have a shorter urethra, so it's easier for bacteria to ascend into the bladder and the kidneys. In addition, their urethra is closer to the anus, and therefore it's easier for fecal flora to enter the urethra. Women who engage in sexual activity can develop UTIs because sexual activity can introduce bacteria into the urethra. Any patient who undergoes a urinary catheterization is at risk for a UTI. When you insert a foreign object like a catheter into the bladder, you can introduce bacteria. In particular, many men are taught to self-catheterize, like what's shown in this picture. Men who have severe BPH and are unable to fully empty their bladder can be taught to self-catheterize, and obviously these men are at increased risk for UTI. And then finally, diabetes and pregnancy are well-established risk factors for urinary infections. Some special risk factors for urinary infections are shown on this slide. The first one is infants with vesicoureteral reflux. So in a baby, the bladder forms like so, and the ureters insert on the two sides. If the ureters insert abnormally, what will happen is every time the bladder contracts, urine will be forced back up into the ureters. This is called ureterovesicular reflux. And one of the things that most protects us from urinary tract infections is normal flow of urine out of the body. So anything that impedes that flow, or even worse, makes it go backwards, makes it easier for bacteria to ascend and cause urinary infections. So I've summarized these points on this slide. Children with vesiculoureteral reflux have ureters that insert abnormally into the bladder, and therefore there's chronic reflux of urine back into the ureters. And these babies will develop recurrent UTIs, and that usually leads to a workup that identifies the reflux. Another risk factor for infection is any cause of urinary obstruction. Once again, the normal flow of urine downward through the urinary system and out of the body is a major protector against urinary infections. So anything that impedes that flow makes it easier for infections to occur. So this could be an anatomic abnormality in a child, it could be a bladder tumor in an adult, and then very commonly it's an enlarged prostate in older men. Now let's talk about the treatment of urinary infections. And in terms of treatment, we categorize patients into one of three categories to determine the appropriate treatment. And those three categories are uncomplicated cystitis, complicated cystitis, and pyelonephritis. Now we've already talked about the differences between pyelonephritis and cystitis, but let's talk about what differentiates uncomplicated from complicated cystitis. In uncomplicated cystitis, there are no systemic signs or symptoms of infection, things like fever or tachycardia, and the infection is presumed to be confined to the bladder. And also in uncomplicated cystitis, usually the patient has no special factors making infection more dangerous for them. In complicated cystitis, there are systemic signs and symptoms of infection, things like fever or tachycardia, but these patients have not yet developed pyelonephritis. In other words, they don't have flank pain and white cell casts and other evidence of infection of the kidneys. Besides systemic signs and symptoms of infection, other things that make cystitis complicated rather than uncomplicated are things like immunosuppression, if the patient has recently had a catheter in their bladder or a procedure related to the bladder, something like cystoscopy, and also hospital-acquired urinary infections are always considered complicated. And then lastly, many people consider any woman who is pregnant or any patient with diabetes or chronic kidney disease to automatically have a complicated form of cystitis. Not everyone agrees with this last point here, sources vary, but I point it out to you now just so you will be aware. The major distinguishing feature between uncomplicated and complicated cystitis is the presence of systemic signs and symptoms of infection, which always makes any bladder infection a complicated case. For uncomplicated cystitis, the most common treatment used is nitrofurantoin for 5 days. You can also use TMP-SMX, which is called Bactrim, for 3 days, or a single dose of phosphomycin. Importantly, fluoroquinolones are not used unless the above treatments fail, and this is important for your boards. Fluoroquinolones are commonly used for complicated cystitis and pyelonephritis, but we don't use them in uncomplicated cystitis unless the usual treatments have failed. And then, as I mentioned before, urine culture is not routinely done. We generally only send the urine for culture if the treatments fail. Complicated cystitis and pyelonephritis are treated the same way, and in actual practice there's a huge variety in the antibiotics that are used, and a lot depends on the way in which the patient contracted the infection. Hospital-acquired infections where there may be highly resistant bacteria present are treated differently than community-acquired infections. But some of the potential treatment regimens I've listed on this slide here for you just to give you an idea. So you can use an IM dose of ceftriaxone plus Bactrim. You can also use a broad-spectrum oral antibiotic like amoxicillin clavulanic acid, and you can also use fluoroquinolones. And fluoroquinolones like ciprofloxacin are popular for treating these forms of urinary infections because they're easy to use. In young, otherwise healthy patients, the treatment is usually outpatient, and for all others, it's inpatient. And many patients, especially elderly patients who develop these types of complicated urinary infections, require hospitalization. Let's talk about chronic pyelonephritis. Chronic pyelonephritis is what happens after multiple recurrent bouts of pyelonephritis. Usually this occurs in children who have vesicoureteral reflux. It can also be seen in adults who have recurrent kidney stones that obstruct the flow of urine. What happens is, over time, the multiple bouts of pyelonephritis lead to scarring of the kidneys, and this is often identified on imaging. If you look at the CT scan on the screen, the left kidney is normal. The right kidney has these dark areas. There's also one here on the outside. That's evidence of scarring from chronic pyelonephritis. If the kidney is removed or if a biopsy is performed, the classic finding in chronic pyelonephritis is called thyroidization of the kidneys. Basically, the tubules accumulate eosinophilic material. This is a picture of what it can look like here on the screen. You can see all this pink material, and that's what the thyroid gland looks like. So because the kidney takes on this appearance, it's called thyroidization of the kidney. Xanthogranulomatous pyelonephritis is a subset or form of chronic pyelonephritis that occurs in a minority of cases of chronic pyelonephritis. Usually it's caused by obstruction of the outflow of one kidney due to infected stones, and for that reason it's usually unilateral. What happens in this disorder is granulomatous inflammation occurs in the kidney, and the inflammation is severe and it can cause the entire kidney to fail. The diagnosis is made by CT scan. The classic finding are multiple rounded dark areas in the kidney. This is called the bear's paw sign. If you look at this CAT scan on the screen, you can see the right kidney is enormous. It's also got these dark areas here, and these dark areas look like a bear's paw, and therefore this is called the bear's paw sign. And when this is identified, it usually requires nephrectomy. That's because the cause of xanthogranulomatous pyelonephritis is ongoing infection and inflammation that has to be taken out. Let's talk about renal and perinephric abscesses. These are usually a complication of pyelonephritis. The patient has bacterial infection of the kidneys, and sometimes a portion of that infection will become walled off and form an abscess. It's called a renal abscess if it's within the kidney tissue, a perinephric abscess if it's within the perirenal fat. So clinically, what this will look like is the patient will have the usual signs and symptoms of pyelonephritis, but antibiotics will fail to improve the patient's overall status. There'll be ongoing fever, and there can even be abdominal pain. And when this happens, the usual thing to do is to get a CAT scan or an ultrasound to see if there's an abscess. If you look at the CT scan on the screen here, the left kidney is normal, but the right kidney has a large abscess. And when you identify an abscess like this in a patient with pyelonephritis, the treatment is to drain the abscess plus continue the antibiotics. And it's important to identify these because antibiotics alone usually won't work. I'll finish with this one slide on interstitial cystitis, also called the bladder pain syndrome. This is a disorder that has all the clinical features of cystitis, but no bacterial infection can be identified. In many ways, it's similar to fibromyalgia and irritable bowel syndrome in that patients have many symptoms, but we don't understand the cause and can't identify a cause. Patients with interstitial cystitis have chronic bladder pain and discomfort, and it must last more than 6 weeks, and there must be no underlying medical cause identified, importantly, no infection identified. It usually occurs in women, and it's common in women who also have concomitant psychiatric disease. And it's a diagnosis of exclusion. We don't make this diagnosis until we've excluded infection and tumor and any other potential cause of cystitis. The first-line treatment, and it's super high yield to know this for your boards, is to avoid triggering foods. Many women with this condition find that certain foods trigger their symptoms, and if they can identify those foods and avoid them, that is one of the best therapies. There are other options, but they're less effective. These include amitriptyline, which is an antidepressant, or sometimes pain medication. And that concludes our module on urinary infections.